Dear ladies and gentlemen, greetings from the Malaysian Obstetric Medicine Society. I think it's timely to revisit a very important topic, an often forgotten topic, tuberculosis in pregnancy. Ladies and gentlemen, I've got no conflict of interest for this lecture, but I've got plenty of issues to highlight with regards to tuberculosis. Before we talk about tuberculosis, there are two important facts that we must appreciate. TB, ladies and gentlemen, like any other medical condition, if diagnosed during pregnancy, can be optimally treated with improved pregnancy outcomes. Now, all those adverse documented pregnancy outcomes are related to two things: TB that is undiagnosed or TB that is untreated. So, ladies and gentlemen, it is essential for obstetricians and anyone managing pregnant mothers to suspect, to think, to diagnose so that we can improve pregnancy outcomes. Now, the highlights of my talk in the next 25 minutes, I would like to talk about the diagnosis and management of active tuberculosis. What is latent TB and who needs to be treated? The concerns about drug and multi-drug resistant TB, which is on the rise in Malaysia. TB is often not just pulmonary, extrapulmonary, sometimes even more common in pregnancy. Think of extrapulmonary tuberculosis. How to manage TB among HIV patients. As obstetricians, we should often always think of perinatal TB, and that is why it's important to think, to be educated about perinatal TB. And often, how to manage a patient who have had tuberculosis, who's keen to embark on a pregnancy. And that forms the gist of my lecture. Ladies and gentlemen, this is the global rates of tuberculosis. Malaysia still is in the area where TB is highly pandemic. And based on these rates, the tuberculosis infection rates in 2020 in Malaysia can be as high as 9.9 per 100,000. Now, this is the World Bank data of tuberculosis. Often when we speak about infection, people often talk about dengue, malaria, COVID, influenza, but we often forget about tuberculosis. Ladies and gentlemen, based on the World Bank data, tuberculosis in Malaysia is on the rise. It is higher in the last few years as compared to 2008, especially multi-drug resistant tuberculosis. If we take a look at the data in more detail, there was a significant reduction in 2004. It went up in 2005. It was lowest in 2006. It went up again. And in 2022, ladies and gentlemen, it is higher than ever before. TB is on the rise in Malaysia. Some TB facts, ladies and gentlemen. 17% increase in TB positive patients in 2022 as compared to the preceding year. In 2022 itself, there were a total of 25,391 adults who were not all pregnant who actually died because of tuberculosis. Now, this rate is 77.8 per 100,000, which is an increase as compared to the rates in 2021. With regards to TB deaths, ladies and gentlemen, since there was a 17% increase in TB positive patients, there were 12% increase in TB deaths in Malaysia. Let's talk about maternal mortality, ladies and gentlemen. I'm sure many would have seen this slide many times. The leading cause of maternal death in Malaysia in 2019 is PPH, followed by associated medical conditions, especially cardiac diseases, hypertensive disorders, and sepsis is the fourth leading cause of maternal death. One important organism and cause of sepsis in Malaysia is tuberculosis. It is a significant cause of maternal death. Now, ladies and gentlemen, here is the data that we looked into the mortality rates of sepsis, especially occurring in the postpartum period. Now, we take a look at the Malaysian MMR, and we take a look at the sepsis alone. 1/4 of mothers who died in Malaysia died because of sepsis. And that is the fourth leading cause of maternal deaths in Malaysia. If you take a look at sepsis and divide them into organisms, if you think it was H1N1, which was endemic in 2009, 2010, 2011, it was not a concern in 2017, 2018. If you think dengue, which is often highlighted, was a concern, it is not. But the cause of maternal death was actually tuberculosis, which is more prevalent as compared to H1N1, dengue, excluding COVID, which was not in existence, we hope, as early as 2018. Now we take a look at a site of infection. Of all mothers who had a puerperal infection, it is usually not the genital tract. It is usually the respiratory tract, then followed by the genital tract, and then urology, hepatobiliary, gastrointestinal, pelvic abscess, and it goes down that way. But ladies and gentlemen, the leading cause of postpartum infection is a respiratory cause of infection. If we take a look at the organism that has been cultured among all the mothers who died in the postpartum period from 2015 to 2019, it is Mycobacterium tuberculosis. So the point I would like to highlight, ladies and gentlemen, think of tuberculosis. Sepsis is important, and one of the many issues, think of a respiratory cause, and think of tuberculosis, because Mycobacterium tuberculosis kills, especially in the postpartum period. Now, what are some TB essentials? The organism is Mycobacterium tuberculosis. It is transmitted, all of us know, through airborne. But airborne alone is not the sole mode of transmission. It can be transmitted via unpasteurized milk, an important advice to be given to all pregnant mothers, apart from wearing a mask. And interestingly, ladies and gentlemen, TB can also be transmitted via skin abrasions and conjunctiva. The outcomes, you may have a latent TB, you may have a primary tuberculosis infection, or you may have a secondary TB, all of which I'm going to discuss after this. But TB is often not always pulmonary. Think of extrapulmonary tuberculosis. TB and pregnancy, ladies and gentlemen. If you have TB, the implications on pregnancy, there's an increase in incidence of anemia, iron deficiency anemia, which is already highly prevalent among Malaysians. There's an increase in the incidence of prematurity, fetal growth restriction, and maternal deaths due to sepsis, like what I discussed earlier. Now, if you flip it all the way around, what are the implications of pregnancy on TB? Pregnancy, like any other infection, increases the susceptibility to primary TB. And more importantly, the patient has got a latent TB or a past history of primary TB. There is a risk of reactivation of TB because of the physiological adaptations in pregnancy. Secondly, diagnosing TB can be challenging. So think of TB. The mother's unwell, the mother's got fever, the mother's got poor weight gain. Think of tuberculosis. And it's highest postpartum. A reason because I think we tend to investigate more and we try to stigmatize women more in the antenatal period. So think of tuberculosis in pregnancy. Now, what investigations, ladies and gentlemen? I think we can divide it into three. Screening, we have got two tests. The TST test, or the interferon gamma release assay, known as the IGRA test to screen. To confirm, we have got two options. Culture and sensitivity, which used to be the gold standard, and microscopy. And additionally, you can use imaging modalities, chest X-ray, and sometimes beyond an X-ray to diagnose tuberculosis. Now, how to screen, ladies and gentlemen? It is known as the TST test. We've got two options. One is the time test, which is rarely used in modern medicine. One that is easily used and more commonly used in this part of the world is known as the Montu test. Now, ladies and gentlemen, one fact about a Montu test, a pregnancy does not cause a false positive Montu test. Now, what causes a false positive Montu test is two things: prior BCG vaccination or a previous tuberculosis infection, but not a pregnancy. Now, having said that, ladies and gentlemen, a Montu test, although it's a good, easily available screening test, it can also be false negative in certain individuals, especially the patient has got a recent tuberculosis, the patient is immunocompromised, which is quite common, the patient has got sarcoidosis, the patient has got a non-Hodgkin's lymphoma, the patient has got a recent live vaccination. So Montu is a good screening test. It can be false positive. The patient has got an HIV, the patient has got a recent active diseases. And sometimes as a screening test, people do the CTB skin test, which uses two antigens, the ESAT6, the CFP10, which is specific for IGRA. Ladies and gentlemen, let's talk a little bit about IGRA. IGRA is far more sensitive. It's modern. It's available in Malaysia. It detects interferon gamma, which is produced following simulation of tuberculosis specific antigens. Hence, the sensitivity is improved, the false negative is reduced. This seems to be another screening, preferably screening test in Malaysia, especially among pregnant mothers, especially if you're not sure whether this is false positive or false negative. Now, if you follow the WHO criteria, there are 4 symptoms that you should exclude tuberculosis. The patient has got weight loss, or in pregnancy, ladies and gentlemen, the patient has got no weight gain in pregnancy. The patient has got a prolonged fever beyond a few days, 3 days, beyond a certain period of time. Think of tuberculosis. The patient has got a persistent chronic cough for weeks. The patient has got night sweats. One of these 4 symptoms, based on the WHO, should alert you towards screening and diagnosing tuberculosis. Now, what are the confirmatory tests? If the screening test is positive, it's good to think of a confirmatory test. It is the microscopy, the favorite Zill-Nielsen screening test. Sometimes people can use the Quinion staining test. Sometimes you can use the fluorescent technique using auramine, rhodamine. Sometimes you can use the loop-mediated intrathermal amplification tests. But what is modern, most easily available in most tertiary hospitals is the Gene Expert, which is a far faster yield, gives you results instantly. You don't really have to wait for weeks like the Zill-Nielsen test, and the Gene Expert seems to be the way forward. And sometimes you can use the LAM urine gene strip test. But having said that, ladies and gentlemen, sometimes using a histological specimen is confirmatory of tuberculosis. On the other mechanism of confirmatory is to use the culture and sensitivity test. You can use the Lovenson-Jensen media, which is a traditional way to confirm tuberculosis. The problem is it takes up to 4 to 8 weeks. You can use the liquid culture media known as BD Bactrum, but the results is slightly faster, 4 to 14 days. But moving forward, ladies and gentlemen, you can use the Gene Expert or can use the real-time PCR, which allows rapid diagnostic purposes. So, ladies and gentlemen, there are new rapid diagnostic tests which is available. Choose your test. Time is of essence, especially during pregnancy. Now, all of us know that radiation is safe. Imaging should not be contraindicated purely because a lady is pregnant. And at all gestations, be it in the first trimester, a radiation of below 50 milligray is safe to the baby. And this means up to a few hundred chest x-rays, up to a CT thorax that is very safe in pregnancy. And beyond 18 weeks, ladies and gentlemen, the toxic level is doubled from 50 to 100 milligray. So radiation is safe. Do not deny the benefits of radiation, especially if you think the mother needs one, especially when you suspect tuberculosis, especially to be used as one of the screening or diagnostic tools. Now, imaging modalities, ladies and gentlemen, you can divide into three. Low dose, which is less than 0.1 milligray, is X-rays. Low to moderate dose will be your CTPA or your CT thorax. And beyond that, ladies and gentlemen, even a PET scan, although it is high dose, or even an abdominal scan or pelvic scan, is usually not contraindicated in pregnancy. Now, for a successful management of tuberculosis, it's not just the physician, but I believe we need to work together with the primary care, sufficient patient support, established support services, and together with a tertiary hospital. And this model of treatment remains true, especially even among pregnant mothers. So it's not often always the tertiary hospital, but for a holistic care, I think we need to break the barrier and manage the patient across the barriers, even in the primary care level. So how to manage tuberculosis, ladies and gentlemen? The take-home message, the gist, is the management is the same for tuberculosis if the patient is pregnant or if the patient is not pregnant. With one modification, the patient should not be on streptomycin. So for active TB, ladies and gentlemen, the initiation phase is 2 months of HRZE, followed by a continuation phase of 4 months of HR alone. The total duration of treatment, 6 months, the same as a non-pregnant mother, provided that streptomycin is not part of the regime, but that causes fetal ototoxicity. 2 months of HRZE and 4 months of HR. What if the patient has got a TB of the CNS system? Then it's slightly different. 2 months of HRZ, but the patient needs a longer duration of treatment, ideally a total duration of treatment of a year. And for TB brain, the continuation phase is 10 months of HR. Ladies and gentlemen, steroids is safe. Dexamethasone is less preferred during pregnancy because of the placental transfer. Prednisolone is the preferred steroids. This is not contraindicated. The patient has got a TB brain. The treatment is usually for 4 to 8 weeks to reduce cerebral edema. It's also important to think that TB is more common extrapulmonary, especially during pregnancy, or especially secondary tuberculosis. So TB extrapulmonary sites are the brain. So any chronic headache during pregnancy, examine the visual field, examine for papillary edema, think of TB brain. TB cannot happen in the eye, can happen cutaneously. Any lymph nodes, which is beyond 7 days, should be biopsied. Think of tuberculosis. It can be musculoskeletal. It can be abdomen, where the patient presents with an acute abdominal ascites. It can be genitourinary. Ladies and gentlemen, extrapulmonary TB is far more common during pregnancy. So what are the red flags of extrapulmonary TB? We spoke about the 4 WHO flags. For extrapulmonary TB, once again, prolonged fever beyond a week, you should think of tuberculosis. Headache requiring opioids, you should be examined, especially endoscopy, and think of an imaging. Pain requiring opioids should be investigated. Severe abdominal pain and ascites, it's good to think of malignancy. Think of an acute abdomen, but send a sample histology to exclude tuberculosis. Nausea and vomiting may be normal in the first trimester, but nausea and vomiting beyond 16 weeks with altered bowel habits. It's good to think of tuberculosis of the gut or cancer of the gut. It has to be investigated. Colonoscopy is not contraindicated. A patient that presents with cranial nerve palsy, think of cerebral tuberculosis. Any non-healing ulcers should be biopsied. Any patient who presents with a tubo-ovarian abscess, think of tuberculosis. More importantly, ladies and gentlemen, if you think a fracture is atypical, if you think a fracture is pathological, if you think the bone quality is significantly affected, if the patient has got Pott's abscess, think of tuberculosis. And any lymphadenopathy or sinuses should be biopsied. And other conditions which are rare, patients with red eye, visual disturbances, chronic scleritis or keratoconjunctivitis, refer to an expert. Think of tuberculosis. Ocular TB is not uncommon. We spoke about active TB. Let's talk about latent TB, ladies and gentlemen. Now, not all latent TB needs to be diagnosed. There are only 3 patients who benefit from treatment of latent tuberculosis. They are patients who are immunocompromised who are HIV positive, patients who have got a high risk of tuberculosis in Malaysia, or who are immunocompromised, or who are pregnant, and patients who have got a positive screening test. But having said that, ladies and gentlemen, although it's good to think of latent TB and to treat latent TB, treatment and diagnosis of latent TB among pregnant mothers is not easy. The recommendation is to, instead of a screening test, move on to a confirmatory test, especially if you're going to start anti-TB treatment among pregnant mothers, or refer to a TB expert for a holistic review. And the treatment, ladies and gentlemen, is isoniazid for 6 months, followed by pyridoxine, which is often always in combination with isoniazid. Or if you think the treatment duration is too long, if you want a regime with a shorter treatment, then there will be isoniazid for rifampicin combination, a treatment of 3 months with pyridoxine. Rifampicin can cause discolorization of the amniotic fluid and urine, but it is safe, it is not harmful, but it's an enzyme inducer. And if the patient needs antibiotics, the patient needs a higher dose of antibiotics. That is the recommendations for latent TB. Perinatal TB, ladies and gentlemen, I think as obstetricians, we must think of a Montu test. We must know how to screen. We must know how to diagnose. We must know active TB and latent TB. But let us not forget congenital TB. Congenital TB can happen. The patient has got an antenatal TB or an intrapartum TB or an active TB. And this means tuberculosis, Mycobacterium tuberculosis can be found in the amniotic fluid. You don't have to send a culture, but a placental HPE is important to think of perinatal TB. So for all patients who have got an active TB during pregnancy, think and send a placental HPE. And sometimes it can also be found in the umbilical vein. Now, postnatally screen for sputum, examine the liver, which is quite a common organ which may be affected postnatally, and any lymph nodes should be biopsied and should be treated accordingly. So, ladies and gentlemen, for all tuberculosis patients, a placental histology and culture is crucial to exclude perinatal TB, which is not uncommon. And such patients can breastfeed because TB is not transmitted via breast milk. It is only transmitted through abrasions, conjunctiva, saliva, airborne, and unpasteurized milk. Now, how about drug-resistant and multi-drug-resistant TB? This is the most common cause of tuberculosis that we see now. The patient has got a drug-resistant TB. I think the management is complex. It's best to refer to a TB expert that I often work together with. So check for sensitivity, ladies and gentlemen. Sometimes if they're sensitive, then give them the 2-month regime. Sometimes another option is to give 3 anti-TB medications with 4 to 7 months or 2 anti-TB medications, depending on the drug that they are resistant to. But even more complicated, if it's not the resistant, patients with multi-drug resistant, usually they're resistant to rifampicin or isoniazid. Then you can add linezolid, which is not contraindicated in pregnancy, or newer medications, which is bedaquiline or delamanid. The recommendation now, ladies and gentlemen, for multi-drug resistant TB is to include linezolid. Now, this study looks into safety and options of various medications to treat multi-drug resistant TB. And one that is easily available in Malaysia, bedaquiline, linezolid, seems to be the way forward. Now, this important study looked into outcomes of pregnant patients with multi-drug resistant tuberculosis who were given linezolid and they had good pregnancy outcomes. So, ladies and gentlemen, linezolid is not contraindicated in pregnancy. Now, what are the obstetrician's responsibilities, ladies and gentlemen? I hope they've established a fact that TB is highly prevalent. Sepsis is the fourth leading cause of maternal death. And among the many causes, respiratory is common. TB is the leading organism. Have an index of suspicion because TB kills, especially in the postnatal period. Streptomycin is the only medication that is not preferred during pregnancy because there's a 15% risk of neonatal deafness. Otherwise, the treatment and recommendation and management is the same for all pregnant mothers as compared to a non-pregnant mother. Isoniazid, ladies and gentlemen, sometimes it is hepatotoxicity. It is associated with peripheral neuropathy. So check the liver to ensure the patient does not have adverse reactions to isoniazid. In all patients on isoniazid, please ensure they are on pyridoxine. It's important to ensure to see whether the mother has got a sputum positive TB, because the last thing you want is a sputum positive TB patient in the ward, in the labor room, or in the antenatal clinic. So it's ensure to exclude that the mother is still infectious. Ladies and gentlemen, a pregnant mother usually needs more medications, not less medications, because of the weight gain, the increase in plasma volume, and the increase in GFR. For some patients, although the recommendations is to use a fixed dosing regime based on the booking weight or the pre-pregnancy weight, sometimes if the weight gain is extremely significant, it is okay to use the current weight, although most people will use a fixed dosing regime. If you suspect resistance, then I think we should think of drug susceptibility. We should readjust dosing regime, not the concentration, but the frequency. And sometimes we can reduce the interval to a 3-weekly regime in the DOTS clinic. And all of this is the responsibility of the obstetrician, not just refer to a TB expert and just do growth scans. Our responsibility is to ensure that the mother has got optimal treatment. Think of the baby, think of the placenta, think of infectious, think of the liver, think of the dose of medications. If the patient has got HIV positive, ladies and gentlemen, then the patient needs a continuation of heart together with isoniazid. And that is the recommendation of TB positive patients among HIV patients during pregnancy, both of which are safe, and perhaps it is the immunocompromised status that predisposes her to have tuberculosis. BCG vaccines, ladies and gentlemen, it is a live vaccine. It is not preferred antenatally, but usually given postpartum. A single dose of universal vaccination is recommended for all mothers in highly prevalent countries, including Malaysia. But a live vaccine is not recommended for mothers who are immunocompromised, mothers who are on biologics such as adalimumab or etanercept, or mothers who have got HIV negative neonates, or mothers with active TB. The live vaccine is not contraindicated. And ladies and gentlemen, although we were taught to look for the BCG scar among all patients when we do a clinical examination, let's remember one fact. A pregnancy does not cause a false Montague test. A BCG scar does not exclude a latent or an active tuberculosis. Now, how about patients who have had tuberculosis but are keen to embark on a pregnancy? I think take a good history. It's good to know the type of tuberculosis, whether it was pulmonary or extrapulmonary. It's good to know whether it's a drug-resistant or a multi-drug resistant TB, because pregnancy, ladies and gentlemen, you can have an activation, and sometimes the activation can be extrapulmonary. Take a look at what were the predisposing factors. Was it BMI? Was it smoking? Was it HIV? Was it diabetes? And is it still there? Because that has to be addressed. Has the patient been on remission? There's no magic number. Is it 12 months? Is it 6 months? Or is it a year? But at least for the predisposing 6 months prior to pregnancy, she should be in remission. And it's not just based on symptoms, but it's based on clinical and imaging to ensure the patient is disease-free. Ladies and gentlemen, in such patients who have had tuberculosis, Montu tests will be unreliable, hence diagnosis can be a challenge. Pregnancy can cause a reactivation. Think of tuberculosis if the mother is unwell, especially if she's symptomatic, she's not gaining weight, and you suspect that she's got anemia or chronic diseases. Think of reactivation. Imaging is safe. Culture and sensitivity should be the way forward. Don't screen, but move to diagnosis. The patient has got a pulmonary TB prior to embarking on the pregnancy. I think a 6-minute walk test is important. Exclude implications of pulmonary TB, looking into the chronic lung. I think these mothers ideally will need a lung function test to ensure she does not have a chronic lung disease. And finally, ensure that her weight has gained, her nutrition has been improved, her liver is normal, have improved from the toxicity of the medications, and she's up to date with the vaccines, especially influenza vaccines. To summarize my talk, ladies and gentlemen, TB is on the rise, and the risk seems to be highest postpartum. But I believe it is postpartum because we have missed the diagnosis antenatally. Pregnancy can cause mother to have an active disease, reactivation of a secondary TB, or reactivation of a latent TB. Have an index of suspicion. The 4 symptoms of fever, night sweats, no weight gain, altered bowel habits. Please do not say this is normal in pregnancy. If it's recurrent, if it's persistent, it has to be investigated. In pregnancy, ladies and gentlemen, extrapulmonary TB is far more common. Think of lymph nodes, think of the brain, think of the cranial nerves, think about the eyes, think about the spine, think about the heart, and think about abdomen. It is far more common to have an extrapulmonary TB during pregnancy. The principle of care: treat the mother the same as a non-pregnant mother, except for streptomycin. Never say it is normal in pregnancy when a mother addresses a symptom. Ladies and gentlemen, latent TB is a clinical challenge during pregnancy. It's important to move on to a confirmatory test, because if you are to screen, if you are to treat, sometimes you're going to render a mother who's well and healthy towards anti-TB medications, which is, although safe, it is not without its concerns during pregnancy. And women at risk of tuberculosis, apart from anti-TB medications, we should also talk about thromboprophylaxis, prophylactic dose of low molecular weight heparin. History is essential. Diagnostic among latent TB patients is perhaps the way forward. If you have a patient who's got multi-drug resistant TB, refer to an expert. Linezolid-based therapy seems to be the way forward. It is safe in pregnancy. The outcomes are better. The patient has got linezolid-based therapy. A multi-professional team is important. A TB expert, a respiratory physician, a maternal medicine specialist who have got good knowledge in medical diseases in pregnancy is the way forward. As obstetricians, think of perinatal TB. The placenta for culture and sensitivity and HPE is important. And ladies and gentlemen, if we are obstetricians working in Malaysia, all of us should be well versed in the management of TB if we are to save more lives and make an impact. With that, this is a good read about tuberculosis. It's the CDC guidelines on TB in pregnancy and the 2022 November publication of tuberculosis in pregnancy in the Obstetrician and Gynecologist Journal. And with that, I'd like to thank you so much for your attention. If you'd like to know more information, kindly visit our website at www.obstetricmedicine.my. And ladies and gentlemen, thank you so much for your kind attention.